Good morning. Today we are going to discuss the pulmonic valve, both pulmonary regurgitation and pulmonary stenosis. The pulmonic regurgitation, the causes include dilatation of the pulmonary ring. The pulmonary ring, like the tricuspid ring, becomes stretched and dilated, and that may result in pulmonary regurgitation of blood back into the right atrium, which causes rising pressure in the right atrium. And if this situation continues, the right ventricle ultimately dilates and starts failing. Now the causes include pulmonary hypertension of any cause. Anything which can cause pulmonary hypertension can result in pulmonary regurgitation. And there is pulmonary artery dilatation that may result in pulmonary regurgitation. For example, a patient may have connective tissue diseases like Marfan syndromes or Ehlers-Danlos syndrome. So they may cause pulmonary regurgitation. Then patients who've got right-sided infective endocarditis, they can develop pulmonary regurgitation. The other less common causes include the carcinoid syndrome, the surgical correction of congenital heart disease. For example, there is congenital pulmonary stenosis. If it is dilated with a balloon, then it can result in pulmonary regurgitation, and is also seen in some patients of tertiary syphilis. Now, what are the symptoms? Symptoms are usually not seen, but this lesion is tolerated for a very long time, as long as the pulmonary artery pressure is normal. When the pulmonary artery pressure starts rising, the patient may start having symptoms. The symptoms are because of the right ventricular overload. Now, what are these features? Patient has abdominal discomfort because of fluid retention. There is increased circulating volume. The back pressure in the right ventricle is shifted to the vena cava, and that results in hepatic congestion. There may be ascites, and the patient may have edema as well. Physical examination, general physical examination may reveal a raised jugular venous pulsation. There may be a prominent A wave when there is pulmonary hypertension. Patient may have dependent edema. There may be enlarged liver, or there may be ascites as well. When we see the precordium, we see the left parasternal lift because of the increased pressure in the right ventricle. So you see left parasternal lift. There may be a palpable component of the second heart sound, that is P2, that may be palpable. Patient may have diastolic thrills. There is a loud P2 with wide split, and there may be right-sided S3 gallop. And when we look for the murmur is called Gram-Steele murmur. Murmur is usually audible when the pulmonary artery pressure is more than 50 millimeters of mercury. With low pulmonary artery pressure, the murmur may not be audible. It may be very faint and may not be picked clinically. This is a high-pitched decrescendo murmur, which is heard in the upper left sternal border, in the second left intercostal space. It is the murmur which increases with respiration and decreases with the Valsalva maneuvers. Now, when we investigate, we may find on ECG there is right bundle branch block. There may be evidence of right ventricular hypertrophy. Chest X-ray may reveal non-specific enlargement of the right atrium, the right ventricle. The echo can tell us about the severity of the pulmonary regurgitation, because this is the investigation of choice for making a diagnosis. It can tell us the size of the annulus, the size of the RV, the size of the right atrium, the functioning of the right ventricle, the paradoxical septal motion. Paradoxical septal motion means that during systole, the high left ventricular pressure pushes the interventricular septum into the right side, but when there is a high pressure in the right ventricle, this pushes the septum into the left ventricle. So this is paradoxical septal motion. Then we can assess the pulmonary artery pressure using echo. Cardiac catheterization or MRI is usually not used, but it can provide us useful information about pulmonary artery dilatation, estimation of regurgitation flow, presence of other structural defects if they are present with pulmonary regurgitation. Pulmonary regurgitation severity and right ventricular functions can also be determined on catheterization and MRI. The management of pulmonary regurgitation is divided between two types. If there is high pulmonary artery pressure or pulmonary hypertension, or is there is low pressure. For example, low pressure like surgical correction of congenital heart disease like or phallostatrology, it is usually valve replacement if the right ventricle is enlarged or is showing a dysfunction. So it's the treatment for low pressure pulmonary regurgitation. For high pressure pulmonary regurgitation, one should treat what's the possible cause. In most of the cases, it may be mitral stenosis. So if we correct the mitral stenosis, the pulmonary pressure starts decreasing and pulmonary regurgitation also starts decreasing. So it may be done. If the patient has high pressure, then we can go for valve replacement, particularly in carcinoid syndrome. Patient has high pulmonary artery pressure and there is infective endocarditis. So in these conditions, we can go for a valve replacement. Now, pulmonary stenosis. Pulmonary stenosis can be both valvular or supravalvular or subvalvular. Now, what are the causes? The most common reason for pulmonary stenosis is congenital heart disease. It can be supravalvular as well, and it may be part of other congenital lesions. For example, it may be present in tetralogy of Fallot, or it may be present in rubella syndrome. So a patient has variable atresia and there may be dysplasia of the pulmonary valve. This may be, as I mentioned, supravalvular stenosis as well. Then patients may have pulmonary stenosis because of rheumatic heart disease, but the rheumatic heart disease is generally not an isolated pulmonary stenosis. There are other lesions, particularly the mitral valve and at times the aortic valve as well. And then you may have carcinoid and the cardiac tumors causing pulmonary stenosis. Now, the long-standing stenosis causes right ventricular hypertrophy due to persistently sustained pressure against which the right ventricle has to push the blood into the pulmonary artery. So ultimately, the right ventricular failure starts after a very long time of this pressure overload. Now, the symptoms in mild cases, it is usually asymptomatic. In moderate to severe cases, patient may have shortness of breath, there may be orthopnea, there may be syncope because of a poor right ventricular output, and there may be chest pain which may be similar to the pain of angina. Patient may have right ventricular failure ultimately. Physical examination may show that JVP may show a prominent A wave, or if there is associated tricuspid regurgitation, there may be a CV wave. Then there may be left parasternal lift with systolic thrill in left second or third intercostal space. The S1 is usually normal, but P2 may be diminished, it may be delayed, or it may be absent even. And one may find a right-sided S4 in these patients because of the high pressure in the right ventricle. The murmur is usually loud, it is harsh, systolic murmur that may radiate to shoulder, and it increases on inspiration. Sometimes this murmur may radiate towards the head as well. The investigation ECG shows right atrial hypertrophy, right axis deviation, and right ventricular hypertrophy. The chest X-ray may show right atrial enlargement, right ventricular enlargement, and there may be post-stenotic dilatation of the pulmonary artery. So this may be seen on X-ray. The echo and Doppler, they can tell us about whether it's a valvular lesion, subvalvular lesion, or a supravalvular lesion. The gradient across the pulmonary valve can be determined, and the function of the right ventricle can also be determined on echo, and one can identify associated lesion, whether there is an MS or an MR, or there is an aortic lesion associated with this, or there are other congenital lesions associated with this pulmonary stenosis. Catheterization is generally not required for diagnosis. Catheterization is only required if the clinical and the echo data are conflicting or they are confusing, or if we are planning intervention or surgery. So in that case, cardiac catheterization may be required. Otherwise, for diagnosis of pulmonary stenosis, cardiac catheterization is generally not required. Then how we assess the severity of pulmonary stenosis? The mild pulmonary stenosis, if the peak gradient is less than 30 millimeters. If the peak gradient is between 30 and 60 millimeters, this is a moderately severe pulmonary stenosis. And if the peak gradient is more than 60 millimeters of mercury, that means this is a severe pulmonary stenosis. Now, what are the indications for treatment? Any patients who are symptomatic, the patients who develop symptoms, for example, they have chest pain or they have syncope or they have features of right heart failure, treatment is indicated. The other parameter is if the resting peak to peak pressure gradient is greater than 60 millimeter, or the mean pressure gradient is more than 40 millimeter, irrespective of the presence of symptoms. So this is an indication. So if the patient is symptomatic, or if a peak to peak pressure gradient is 60 millimeter, or if the mean pressure gradient is more than 40 millimeter, this is an indication for treatment even if symptoms are not present. Now the treatment is either percutaneous balloon valvotomy or valve replacement. Valve replacement is done if there is associated pulmonary regurgitation or if the valve is severely dysplastic. So in those conditions we go for valve replacement straight away. And if percutaneous balloon valvotomy is done, when the mean pressure gradient across the valve is usually 50 millimeter or more, we can go for a percutaneous balloon valvotomy. But the problem with balloon valvotomy is that the valve tightens again, and this may produce stricture, and that may require further valvotomy again. So this is the treatment option for the pulmonary valve stenosis. This was about the pulmonary valve. Next time we will discuss another cardiac condition. Till then, goodbye.